ये अपन अच्छा हाँ
Good evening, everyone.
Good evening.
Good evening, Doc.
So welcome to today's webinar. I'll give people a few more minutes, just maybe 5 more minutes, so that we can have as many people join in before we start. Okay, I think we can start. Good evening, everyone. My name is Dr. Stacy Njani, and I will be the moderator for today's webinar. The topic for today is Untangling the Chaos, Bipolar, Booze, and the Path to Stability. And we have our one and only Dr. Saddam, who will be the speaker for today. And I will give him a chance to project his presentation and we can get started. I see we have about 50 people on. Hopefully we have quite a few by the time we get started. As I give Dr. Rajab a chance, I'd also like to welcome today's sponsors for the webinar, Synamed. They're with us here, and we'll have a chance to hear from them, hear the products that they have with them for us today, and a few papers that they'd like to present to us, just to support, to give us some evidence-based data on some of the medications that we use. Dr. Rajab, our CME coordinator. Can you hear me?
Sorry about that. Good evening. Am I audible now?
Yes, Doc.
Sorry, some technical hitch.
You are
devices.
audible, Doc, loud and clear.
Thank you. Good evening once again. Thank you, Dr. Stacy, for the warm welcome. Thank you all for those who've made time to be here this evening. Like we have been prepping for this CME, we would like to discuss the interplay between bipolar and substance use and how our patient can eventually lead a normal life. Okay, I want us to meet Joe, not his real name. but it's the name we are going to use. So Joe is a 24-year-old student at one of the universities in our country. He's single for now, a second born of 3. Both parents are alive, but have since separated. Since the separation, he's predominantly lived with the mother. He is currently a 4th-year student pursuing Bachelor of Education. At the time of the review, he was accompanied by his roommate, and collaborative history was also acquired from the mother via phone, who at the time had traveled up country. The allegations at the time of the review was that for the past 4 days, Joe had not been sleeping quite well. He had also been noted to be talking excessively. He was very restless, and according to the roommate, he was all over the place. He was causing disturbance at the halls of residence. He was very irritable. He had even gotten into a fight at the halls, and also it was noted that he was drinking more than usual and specifically hard liquor. The symptoms had been worsening over the past 5 days. The roommate noted a significant change in, the roommate noticed a significant change in his behavior after he had lost a large sum of money while he was trying his hand in forex trading, a little bit over 450,000. This distress is what now triggered this current episode. When we look at his past psychiatric history, Joe had a first episode of mental illness at the age of 17 years. At the time, his older brother had been involved in a road traffic accident and was in critical care for 6 weeks. The mother reports that he started becoming very restless, talking excessively, being very irritable. He did not sleep much, and he actually claimed could do a better job than the doctors at restoring his brother's life. At the time, he was treated with quetiapine, and he did stabilize after 3 months and was lost to follow-up. A second episode occurred when he was 19 years. This time, the trigger was a separation of the parents. It was observed to be in low moods, lack of energy, poor appetite, lost interest in his day-to-day activities. He was hopeless, and mother reports that also he did mention to have had suicidal thoughts. This time round again, he was treated with quetiapine and escitalopram. You can understand the combination here, given the first history at 17 years, why, despite the symptoms predominantly looking depressed, the option was not to go with the monotherapy with an antidepressant. As I had alluded earlier, on both occasions, when he felt better, he was lost to follow-up. But more importantly, this time round, is that he complains the medication caused him significant weight gain. And on top of that, he also claims to have been healed and did not need to continue with medication. The roommate, who has now been with Joe for the past 2 years, reports that he's observed on multiple occasions when Joe has been what he calls a bit too much. He has observed times when he's too excited, could function with very little sleep, spent a lot of time online writing, doing online writing, and now the money he gets there channels it to forex trading. And during these periods also, his drinking habits were a bit beyond what they could term normal for their routine drinking at campus. When it comes to family history of mental illness, of note is that the mother has been treated for major depressive disorder in the past, currently not on medication. There is a paternal uncle who is on treatment for bipolar mood disorder. On examination at the time of the review, Joe was well kept, in very high spirits. For someone who we are meeting for the first time, I could term that he was a bit disinhibited. His speech was pressured. He had racing thoughts. He was very grandiose. He claimed that he was on his way to be a dollar millionaire, and that is why actually the system was working against him and to disenfranchise him. And he also was claiming how he is actually in the verge of importing a very luxurious vehicle. He was very restless. However, he was still oriented in time, place, and person, and had no insight. We did some baseline investigations, complete blood count, UEC, liver function test, thyroid function, urine toxicology, HIV, serology, and an abdominal ultrasound. The ultrasound did show a grade 2 fatty liver. Most of the other investigations were essentially normal, apart from the liver function test, which we'll talk about in the next slide. At this point, diagnosis of bipolar mood disorder type 1 in a manic episode was made. And we moved on to stabilize Joe. He was admitted for a period of 7 days. De-escalation on its own didn't work, so midazolam was used to stabilize him and calm him down. He did refuse quetiapine at this time. As a rule of thumb, if a medication worked in the past, it's prudent to go back to it. But in our case, Joe was adamant about quetiapine especially. So we convinced him to onboard on divalproex this time round at 500, which later, by the time we were discharging, was at 750 milligrams. At this point, the liver function tests came back, and I would like us to take a look at the one dated 20th of January, because that is the one that actually did draw us to the attention of what also we needed to add in the management. Is that the AST at this time was 75, the ALP was 128, and the gamma GT was at 1,106. And at day 2 of inpatient care, we also did start noticing that Joe had some fine tremors. He could get in and out of lucidity. So at this point, we also figured that Joe was also actually having withdrawals from alcohol. He had downplayed it at the time of admission, of course, expected. And on follow-up, while updating the mother actually now remembered that during the December holiday, there was a time Joe had complained of very severe abdominal pain, had even one episode of vomiting, and the liver function test at that time, which was December 13th, was shown now on the first column with an AST of 143, which were much, much higher than when he now came to us in January. ALP was at 219 and gamma GT of 1430. At the time, the doctor actually did advise him to cut down on his consumption. Evidently, he tried, but still not good enough at the time. So it meant we needed to also support him by now managing the withdrawal symptoms with the IV vitamins B and C, 1 and 2, a tapered dose of diazepam, and at the same time, we did introduce metadoxin, 500 milligrams BD. And even as he was continuing with treatment, we now, being in the first contact people, the roommate and now the mother, were the first people we had to psychoeducate as we waited for Joe to stabilize. At this point, our diagnosis was revised to be bipolar mood disorder with comorbid alcohol use disorder. Why I put this here is because it will not feature in the management of bipolar mood, but it is a molecule that I think as clinicians we may need to pay more attention to, metadoxin, especially its benefits to the liver in patients with alcohol use disorder. This is a study that was done in Mexico. And there were 135 participants Of these, 35 participants were put on prednisone alone. And these are patients who had severe alcohol hepatitis or alcohol-induced hepatitis. Of the 135 that met the criteria to be included in the study, 35 were put on prednisone alone, 35 were put on prednisone and metadoxine, then 33 patients were put on pentoxifil alone, and 32 patients were put on a combination of pentoxifilin and metadoxine. At 3 months, the survival rate of those who were put on a combination of prednisone and metadoxine was at 68.6%, while that of those who were on prednisone alone was 20%. And the patients who are on metadoxine pentoxifilin combination, the survival rate at 3 months was 59.4%, while that of pentoxifilin alone was 33%. And at 6 months, again, the combination of metadoxine, pentoxifilin, the survival rate was at 50 vis-a-vis 18% of pentoxifilin alone. And at 6 months, prednisone, metadoxine survival rate was at 48% vis-a-vis 20% of prednisone alone. So in these scenarios, we see the benefits of metadoxine in improving the outcomes in patients who have liver injury secondary to alcohol use. And the benefit of pentoxifilin when you have, of metadoxine when you eventually do get to read this article is that it not only helps with recovery from the injury out after the liver damage, but it also promotes abstinence because it reduces the cravings to alcohol use. The link will be at the end of this presentation in the references for your consumption. After 1 week of treatment, there was significant improvement. Joe was less agitated, sleep had improved slightly, pressured speech was less, still was grandiose, and insight was still poor. Remember, we had already discharged him at divalproex of 750. So we added aripiprazole at 15 milligrams nocte, and he continued with metadoxine. At 3 weeks, Joe was now much better. He had even started resuming some classes. Insight was partially there. And at this point, psychotherapy now was also of benefit to him to continue to build insight and also to be able to now help him build resilience. That is the end of my case study. In case of any questions, we will tackle them at the end of it. But it was just a preamble as we tackle mood disorders, bipolar mood disorder. And for the purpose of this presentation, we'll limit ourselves to bipolar type 1. If all goes in according to plan, the second phase of this conversation will be had next month when we will be talking about bipolar 2 and psychothermia. So bipolar disorders as a whole, they are chronic and persistent psychiatric conditions characterized by periods of prolonged and profound depression, which alter with manic episodes or hypomanic episodes. And in between, there is periods of remission. Bipolar in the past has been associated with what has been termed as creative madness, especially in the hypomanic phase. And there is actually evidence that there is a lot of patients who in the hypomanic phase where they still can function, they would in fact resist treatment because they allude their creativity improves or is at its optimal at this point. And symptoms may vary from patient to patient and also within episodes. Emphasis should always be given to the life history of the patient and collaborative history because the nature of the illness, the prodrome phase of bipolar mood is that the diagnosis can be challenging. When we do look at the treatment guideline, we will be seeing how actually there is evidence that there is delay in diagnosing bipolar to up to 10 years of misdiagnosis. And the commonest misdiagnosis is usually major depressive disorder, schizophrenia, and other psychotic illnesses, ADHD, and borderline personality disorders. And this misdiagnosis also conveniently form what would be the natural differentials for bipolar mood disorder. The DSM-5 classification of bipolar mood disorder has captured these disorders under the mood disorders. There's the bipolar 1, bipolar 2, cyclothymic, and then substance or medication-induced bipolar and related disorders due to another medical condition, other specified bipolar and related disorders, and then unspecified bipolar and also unspecified mood disorders. Like I said, due to time constraints, we will tackle bipolar 1 today, and then we will have some other time to do bipolar 2, cyclothymic, and most of the others will actually fit or be sorted out in this conversation as we continue. The epidemiology, sorry. So the prevalence of bipolar is at about 0.3 to 1.5, with bipolar 1 being at 0.8 and bipolar 2 at about 0.5. Males are affected equally to females. However, bipolar 2 mostly is seen in females vis-a-vis the males. First episode for most males is a manic episode, and first episode depressive phase mostly will occur in females. Here I have captured the peaks possibility being 2, but actually there's also literature that says there could be 3 peaks of bipolar, with the age of onset being captured as from as low as 15 years to as high as 50 years, with a mean age of 21. The first peak being between 15 to 19 years, the second peak 20 to 24, and there's literature that says there's a peak actually 40s towards the 50s. So 3 peaks, not the 2 that are here in this. The causes of bipolar mood is multifactorial. Sometimes it is unknown, actually most of the time, but genetics does play a very, very big role. When it comes to first degree relatives, the heritability is actually up to 7 times more likely to develop this condition if you have a first degree relative who has had bipolar mood. And children of patients with bipolar mood have a 50% chance of developing any mental illness, not necessarily bipolar. Overall heritability of bipolar mood is up to 70%, with monozygotic twins having a higher risk of 33 to 90%, while dizygotic twins, just like other siblings who are not twins in the family, is at a low of 23%. There are also environmental factors that come into play. Even with genetic risk, most of the time is that it will wait for an interplay with the environment. So adverse life experiences play a very significant role, and stressors like pregnancy also play a very significant role. We've seen many mothers who have had their first episode either of a depressed phase or a manic episode just around the times of pregnancy and childbirth. Pharmacological causes, antidepressants, we've heard about switching, where especially a patient who presents with first episode being a depressed episode and you treat as depression, and then they switch to a manic episode, and then the use of stimulants, cat, meth, and all the other substances that we consider stimulants also has caused patients to develop their first or subsequent episodes. Bipolar mood carries a very high morbidity rate. The amount of productivity or productive years or the years of disability that it causes is very significant in terms of lost work, lost productivity, the ineffectiveness to perform at school, the effects it has on relationships. It's very significant. Attempted suicide is in up to 20 to 50% of cases. Completed suicide in up to 10% of cases. females will attempt suicide more than males, especially during a depressive phase, but males will succeed more in completing suicide more than females. So statistically then, at the end of the day, it will show that more males than females will die by suicide, but more females will have attempted suicide. Some substance use is a very significant comorbid, like we've seen with our patient Joe, is that alcohol use was his comorbid condition. Most patients with bipolar, when you are evaluating, remember to screen for comorbid substance use. This is just a reminder of the DSM classification or diagnostic criteria for a manic episode. It will need at least 7 days duration of abnormal or elevated, expansive or irritable mood, abnormal or increased activity, grandiosity, decreased need for sleep, being more or excessively talkative, having racing thoughts or flight of ideas, being distractible, increased in goal-oriented activities or psychomotor agitation, disinhibition, and a disturbance is significant enough that it impairs function. And this last statement is actually what usually separates this from bipolar 2, that in bipolar 2, somehow function is maintained. But these same symptoms will occur in hypomanic state, only that the duration is a bit shorter and the function is not significantly impaired. The depressive phase of bipolar mood is exactly the same as that for major depressive illness, at least a 2-week period of depressed mood, a lack of interest in day-to-day activity, significant unintentional changes in weight, sleep disturbances, psychomotor agitation or retardation, low energy, fatigue, worthlessness, poor memory and concentration, recurrent thoughts of death, and these symptoms also cause significant impairment in function. For a lot of the mental illnesses, actually what brings patients to care is the impairment to function. Otherwise, for as long as patients can function, more often than not, they will delay coming to hospital. This is just a diagram to separate bipolar 1 from bipolar 2. I think the take-home message here is that you can first be diagnosed with bipolar 2 and graduate, so to speak, quote unquote, to bipolar 1. But once you've been diagnosed with bipolar 1, you can never be bipolar 2. And for bipolar 1 is that there must have been a manic episode. And the need for a depressed episode or a hypomanic episode is not necessarily, it can be plus or minus. But for bipolar 2, both the depressive and the hypomanic episode need to have been demonstrated. So you may find a patient who has been having hypomanic episodes for a very long time, let's say 7 years, and depressed phase, and then one time they actually have a full-blown manic episode. So this patient that we've been managing as bipolar 2, then the diagnosis changes to bipolar 1. And we may have a patient who at 15 years had their first manic episode, and for the rest of their life, they never have another manic episode. The diagnosis still will remain bipolar 1. When assessing a patient with bipolar, these are just some of the things to consider. Number of previous episodes, including subclinical ones. Remember with Joe, we talked about how during the holidays, the mother reports there was a period he was drinking very heavily until they had to go see a physician. The roommate reports a number of times that Joe has been a bit too much. So these are what we would call subsyndromal episodes that never got to care, but chances are they were happening either way. You have to consider average length of previous episodes, average time between episodes, level of psychosocial functioning between the episodes, previous response to treatment, family history for mental illness, history of substance use, and suicide risk has to be evaluated. This underscores the importance of collaborative history and just taking your time with the patient, being able to try and walk this journey with them through the lifespan, so that maybe you do not miss any detail. Suicide risk in bipolar is very, very important. And every time you are evaluating a patient with bipolar, it is important that you actually do take time to evaluate the risk for suicide. Worldwide, 43% of patients with bipolar mood have suicidal ideations. 21% have a plan, and 16% have attempted suicide within the past year. Of those who have attempted, 6 to 7% of patients with bipolar will die by suicide. Remember, initially there was a statistic that actually captured it at 10%. And suicide risk assessment is of utmost importance, especially during a depressed phase. 70% of suicide deaths and attempts occur during this depressed phase, especially when it is also mixed with mixed features of anxiety or psychosis. Then this is an important thing to also put into consideration. The most common method of suicide in this population actually is usually self-poisoning. So in the very first phase of treatment, you may actually need to be cautious about the amount of medication you are sending the patients home with. Is there a good social support at home as you send them home? Otherwise, what you may be giving as the tools for a good outcome may again be what is used against us. 14% of suicide deaths occur during an inpatient stay, and 6 weeks within 6 weeks of discharge, there is another 26% of patients who will attempt suicide. When it comes to management, we are going to, for the sake of time and also just being brief, we are going to limit our approach to these two guidelines: the CANMAT guideline on management of mood disorders 2018 version, and our national clinical guidelines for management of common mental disorders. We start by management of a manic episode, and in this case, the agitated patient, just like how Joe was. And the first line, I won't go through everything. I'll just mostly stick to what is first line recommendation, and then I believe the slides will be provided, and we will also have this presentation uploaded on YouTube at some point. So for quick sedation, aripiprazole, I aim up to a maximum of 15 milligrams per day is recommended as first line. Lorazepam, also I aim 2 milligrams is another option. And olanzapine, I think those ones are the ones that are easily available in our setup. When you go to the second line, haloperidol injection or a combination of haloperidol and midazolam is also an option you can consider. When you check conveniently in the third line, is that we still have options that we can use, especially in our setup. So these drugs are still effective in helping with the agitated patient, especially if they can be able to take orally. Haloperidol per oral, quetiapine is there, and also risperidone per oral 2 milligrams are also options you can consider if you do not have the IM options at your facility. When it comes to the management of acute manic episode, lithium remains the gold standard. All through, it is recommended. Quetiapine is also a very good option for the management of acute manic episode. Divalproex comes in third, and it has fairly good efficacy, especially when it comes to acute manic episode, prevention of any mood episodes. And then when it comes to prevention now of mania, it has level 2 evidence. When it comes to prevention of a depressed state, it has level 3 evidence. Aripiprazole is also there for the management of a manic episode. Paliperidone, more than 6 milligrams. So if you have paliperidone in your facility, don't start with the lower doses if your aim is to try and stabilize a patient in a manic episode. Risperidone is also there. And then when it comes to combinations, first line combination treatment, if you must, monotherapy is what we recommend most of the time, but sometimes we find ourselves having to augment treatment. So the combination of quetiapine and lithium or quetiapine and divalproex is a recommended first line treatment in combination therapy. Aripiprazole in combination with lithium and or divalproex is also recommended, same as risperidone. Yeah. Second line treatment, olanzapine and lithium or divalproex combination. Carbamazepine is also there. This one we love so much. So it has its place in the second line combination treatment therapies. And the benefits of ECT, I think we should not overlook. There are situations where ECT will benefit us even as we wait for medication to kick in. In acute setups, especially after postpartum manic episode, and you want the mother to stabilize in good time, it is important to think of ECT early on in treatment. In the management of an acute depressive phase, again, quetiapine, first line, all green, a very good molecule if well tolerated. If you can strike a therapeutic alliance with your client or patient, quetiapine is a molecule to always have in mind for management of bipolar, be it manic or depressed episode, or even maintenance treatment, as we will see in a short while. Lithium is still there, so it is still gold standard, still very good. And lithium should be used if you have managed to get with your patient to an understanding that compliance is key. The monitoring that is needed will be done so that you always ensure that you are within the therapeutic window. Then lithium is something to consider. Lurasidone, with combination with either lithium or divalproex, is also a very potent treatment for bipolar depression. Lamotrigine, and then lurasidone as monotherapy, and then lamotrigine as an adjunct. Second line treatment, divalproex as monotherapy, then adjunctive treatment with either SSRIs or bupropion. The three antidepressants that have actually equivocably been recommended by the CANMAT guideline are bupropion, sertraline, and venlafaxine. And they try to really discourage the use of antidepressants, de facto antidepressants, in the management of depression in bipolar mood, but rather use the first line alternatives up there. But in case you do need, then those three should be maybe what come to your option list first before you consider the conventional antidepressants that we use as first line for major depressive illness. ECT still has its role. And then at the bottom of the table, there's the combination therapy, olanzapine, fluoxetine, a molecule that actually does have good therapeutic functions. In fact, when we will be having a peek at our national guidelines, this combination is preferred to any individual antidepressant alone as treatment for bipolar depression. For maintenance treatment, whether the patient presented in a manic episode or a depressed state, once now they are stable and now you want to continue, first is that remember less is more. Always aim to try and have the patient with a single molecule. And then in the unfortunate event that you need to augment, then the options are there. Lithium still is king. Quetiapine, divalproex, lamotrigine. Then we now come to our combinations of either quetiapine with lithium or quetiapine with divalproex, aripiprazole with lithium or aripiprazole with divalproex, or aripiprazole as monotherapy, though there's no data of its benefits in a depressed state. There's room for long-acting injectables. and there's benefits for this, especially for maintenance treatment. It also is good just to ensure or confer compliance. There's lurasidone down there as well, paliperidone, more than 6 milligrams, or paliperidone long-acting injectable as well can be considered. So these are just excerpts from our local guidelines. It just talks about the symptoms of a manic episode, how to assess the patient, the differential diagnosis that we have talked about. Remember, we started with the MDD, major depressive disorder. There's anxiety, substance use by ADHD, and then also you have to screen for other medical conditions. Why especially screening for HIV is important for patients with bipolar mood is that in the face of a manic episode or a hypomanic episode and the disinhibition kicks in, one of the things that also comes with this is hypersexuality, and sometimes they engage in very risky sexual behaviors. So it is good to just screen so that in case then there is comorbid HIV, also pick it. Don't miss and focus on treating the patient for only the mental illness and then forget to look at the patient as a whole. And the recommendations are there for acute depressive episode. Quetiapine for our local guidelines is recommended. The combination I was talking about, olanzapine and fluoxetine, lurasidone as monotherapy or with combination with lithium and divalproex. Our local guidelines actually strongly discourage the use of antidepressants as monotherapy for bipolar depression. And for manic episode, the use of mood stabilizers or an antipsychotic is recommended. And when coming to maintenance treatment, again, just like we've discussed, either a mood stabilizer alone like lithium, divalproex, or lamotrigine, or an antipsychotic like aripiprazole, olanzapine, risperidone, quetiapine. There's room for long-acting injectables. There's indications for ECT. Psychotherapy in the initial phase of a manic episode is of no use, but psychoeducation to the parent, psychoeducation to those who are close to the patient is very important. But once the patient stabilizes and then once the patient stabilizes in case of a manic episode, then psychotherapy now becomes of importance. But when now we talk about bipolar depression, psychotherapy is important both in the acute phase and also in the maintenance phase. And all the other social interventions also are very important. And in case you need to refer appropriately. If you are not in a setup where you're comfortable to administer or initiate lithium, refer to a place where levels can always be monitored, and so that safety is also taken into account as we try to stabilize our patients. And I think that is it. These are my references. I thank you so much for your time. Back to you, Dr. Stacy.
Thank you so much, Dr. Rajab. For those who's joined us a bit late or when you were in it, that was Dr. Rajab Saddam. He is a consultant psychiatrist at the Kenyatta National Hospital and our CME coordinator here at KPA. And that was a very detailed presentation we've just been taken through. I think a few things have stood out for me, one of them being the importance of corroborative history. In your case study, having a mother and a roommate to speak to helped you tie some pieces together that otherwise the patient himself might not have told you. Like you said, creative madness. And I'm sure a lot of us come across these patients where you can clearly see clinically they're not well, but then for them, they're almost enjoying whatever is happening. And it becomes quite difficult to establish compliance at that point. And so it's very important for us to have corroborative history. I think you also brought up something about how we can shift from bipolar mood to mood disorder to bipolar 1. I don't think I've had that conversation before, and that was a very good point to bring out. So thank you so much, Dr. Rajab. If anyone has any questions, please put them in the chat box. We'll hear from our sponsors for the day before we can address any questions. So if you have any questions, put them in the chat box, or you could hold off a few more minutes and you have a chance to ask them to Dr. Rajab. So thanks so much, Doc. And now I'll invite our sponsors for the night. Please.
Thank you, Dr. Stacy, for inviting us. Dr. Stacy, can I share my slide now?
Yes, please. Yes.
Dr. Stacy, is it visible, my slide?
Yes, very well. You may go
Okay.
on.
Okay. Thank you. Good evening, Doc. First of all, on behalf of Sign and Med, I am accompanied with our GM, Mr. Sumir Raina. So we are two are from Sign and Med. Along with that, our Med Rep and our country manager also are into the CME. First of all, on behalf of Sign and Med Pharmaceutical, we sincerely thank Dr. Rajab for such an enlightening session, and also Dr. Stacy and overall KPA for giving us the opportunity to be part of this presentation. And also, on behalf of Synermed, I would like to thank all the doctors who have participated on this discussion. Now, without further delaying, I just take few minutes to share, because already Dr. Rajab had shared some of the case study about bipolar disorder, alcohol use disorder. Now, as we got the opportunity, just I made some few slides where some of the recent article which talk about what is the prevalence of alcohol use disorder in Kenyan region. So AUD is rising in Kenya. This is a very recent article which was published in November 25, 2024, last year only, in the Standard. The article was Alcohol Abuse in Kenya, Grim Statistic and a Call for Bold Reform. In this article, it has been shown that overall 12.2% of Kenyan aged 15 to 65 consume alcohol regularly, with 10.4% suffering from alcohol use disorder. And the more alarming situation is the average age of onset is 11 years, and with some cases it is starting as young as 4 years old. I think this statistic gives more relevance to today's discussion about alcohol use disorder. What are the different symptoms, how to manage. My next article is also, it is a article which published in NTV, which talk about within Kenya, particularly the western region, the alcohol consumption or alcohol use disorder are more. With the percentage consumption in western region, it is in the survey, it is found around 26.4%. The coast region around 13.9. In central Kenya, it is around 12.8. And the lowest being in Nairobi region, which is around 10.3%. And the third article, the last article I show, this is one of the study which was done in Kenya. I think some of the author might be present in today's CME, which was published in African Journal of Empirical Research in 2023. And this study or survey was done particularly in Bungoma County, where among 762 respondents, it was found that 78.2% met the lifeline criteria for at least one of the 4 screened mental health condition, where depression was the most prevalent, around 73.8%, and which was followed by bipolar mood disorder around 13.8, and psychosis around 1.8. So I'll conclude my presentation regarding the roadmap. I am sure the major 2 road work ahead is the awareness and destigmatization, because still people having a lot of stigma about mental health disorder and going to the doctor for screening. And I am sure that really appreciate that KPA doing fantastic job in doing a lot of awareness and putting effort on removing all those stigma about mental health disorder. And as a pharma company, as a signer made, our job is to regarding accessibility, to bring affordable evidence-based psychiatry treatment to more number of patients. And at SignRMed, we believe that real change begins with science, compassion, and accessibility work together. And as a result, we are the company to launch metatoxin alcomet, first time in Kenyan market. Before alcomet, the current therapy, if I see in alcohol use disorder, which is naltrexone, which is even the cost of the therapy, because in those mental health disorder, the major constraint is getting the patient screened and putting them on medicine, and the cost part is also one of the problem. So with the launch of Alcomet, we bring down the treatment, alcohol use disorder treatment with naltrexone. It was almost, we have reduced 1/10. One tablet of naltrexone costing about 900 to 1000 shilling, whereas Alcomet, one tablet cost less than 100 shilling. And not only that, Alcomet having another advantage, not only it take care of the craving and abstinence, but at the same time, it has a role on as a hepatoprotective. So thank you very much, Dr. Rajab, for putting the case studies on your patient on Alcomet. And apart from Alcomet, we have another brand, Dival Scan Ear 500, which is Dival Pro sodium extended release 500 mg tablet. And apart from that, we have also launched Schizoral, which is aripiprazole tablet, 15 mg scope tablet. So these are the three brand. Along with Nuventa also we have brand, which is a brand of methyl cobalamin, alpha lipoic acid, and other vitamin and minerals. Thank you very much to KPA, Dr. Stacy, Dr. Rajab Saddam, for giving us this opportunity to be part of this presentation. Thank you very much. Good evening to all.
Thank you so much. I think this is a very good discussion we've had. Most of us come across patients who are we're managing for alcohol use disorder, and we often don't know what to do to support the liver. So our attention being brought to metadoxin is good, so that we can have all the options available to us to help our patients. Do we have any questions? I don't see any questions in the chat box. We are 4 minutes to 8 p.m. I'd like to leave the space open for anyone who'd like any questions, both for Synomed or for Dr. Rajab, to have this opportunity. Any questions? Okay, if we don't have any questions, Dr. Rajab mentioned that we'll have the presentation up on we have the presentation up on the KPA YouTube channel for people to watch later on, and the presentation will also be shared on the various groups. I'd like to take this chance to thank everyone who attended today. Thank you, Dr. Rajab, for that exquisite presentation. It was quite detailed. I think we don't often see very clear symptomatology like we have in your case study. And it's good for us to see that and know that certain things, such as screening our patients for suicide risk when it comes to bipolar, is important. I think we often overlook that and focus only when we have patients with MDD. So thank you so much for all the pointers that you've brought up. And with that, I'd like to bring today's discussion to a close. Until the next one, have a good evening.
Thank you, Dr.
Thanks, Rock. Good evening.
Thank you. Good evening.